Well, great. Welcome everyone to the Washington State Telehealth Collaborative. I think we're going to get started. Maybe what we can do is start with introductions. We'll start here in person, and then we'll go to the phone and video. Sheila, you want to kick it off?
Sure. I'm Sheila Greencheck, and I represent the Washington State Health Information Management Association.
Chris Cable with Kaiser Permanente, Washington.
Joe Schmidt, 9th Legislative District.
Francis Scott, Molina, Healthcare.
Jenny Lorden, Providence, St. Joseph Health.
Cartel, University of Washington, Department of Psychiatry. Phil McGraw, University of Washington.
John Scott, University of Washington.
University of Washington. City County, Multi-Church.
And let's go to video. Dr. Jimenez.
Ricardo Jimenez, CMO of Seymour Community Health Centers here in Seattle.
Great. Good to see you. We're going to go to the phone now. If you're on the phone, could you please unmute and introduce yourself, especially if you're a member of the collaborative?
Dr. Scott Kennedy, CMO at Olympic Medical Center, Port Angeles.
Good afternoon, Scott. Good to hear your voice.
Thank you, John.
This is Jenny Cruz, Seattle Cancer Care Alliance.
Hi, Jenny. Of other numbers there. You can introduce yourself.
I'm Josh Frank.
Oh.
Hi there. I'm Josh Frank. I'm Medical Director, Emergency Department at Central Washington Hospital, representing American College of Emergency Physicians, filling in for the usual member of the collaborative.
Thank you. Thanks, Josh. Other people want to introduce themselves, please?
Nancy Lawton, ANPs United of Washington State.
Hi, Nancy.
Jody Kunkel, Healthcare Authority.
Hi, Jody.
Sean Ekavan, Medical Director, AmeriGroup.
Good afternoon, Sean.
Cheryl Huchala, Primera Blue Cross.
Hi, Cheryl. Happy New Year.
Thank you, you too.
Brody, I think you were going to come. And there's Brody Duchenko on the line. No, not yet. Okay. I see Mark Lowe from Seattle Children's.
Hi.
Hi, Mark. I know you can get on video, so I expect to see you on video here. Unless you're using Blue Jean. Yeah, and just a reminder, if you can please mute yourself if you're not speaking. Other people want to say hello? Okay, well, great. So what we want to do first is to review the minutes from our last meeting, and then turn it over briefly to Chris to just give us a short welcome and overview of the Kaiser program, and then we'll turn it over to Rouge to talk about health economics. But why don't we first review the minutes from 11/17, and a big shout out and thanks again to Dr. Jimenez and folks at Seymour for hosting us then. So I'll give folks the opportunity to review that. For the people who aren't here in person, you can check your email. Priscilla sent those out earlier today. And that thumbs up from Chris here. Any other clarifications, comments? Can I get a motion to approve the minutes? Second, please. Second. Discussion? Okay. All those in favor of approving the minutes, say aye.
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 Thank you. Any no's? Great. Okay. The minutes will be available on our website soon, and we'll make those available to the public. So, Chris, thanks for hosting introducing us a little bit about Kaiser, City Group Health. What are you guys up to? Yeah, so welcome to our primary administrative campus here for Kaiser Permanente. Yes, formerly Group Health, celebrating our 1-year anniversary on February 1st at Kaiser Permanente. And we have about 650,000 members across the state. Our major model is that we have combined care and coverage, and so I think that's actually played a lot in the telehealth arena because by and large we haven't had the right clinician group around payment issues, so we've been able to innovate and work with telehealth for many years. We've long had secure messages, telephone visits, especially consults done virtually. We do millions of secure messages each year, and last year we started to add video and e-visits, and we're actually going to start adding a chat function in the next couple months where patients can talk to us or a nurse practitioner or a PA about whatever they want to resolve it or triage it. Along with part of the way we do medicine and practice, part of our DNA, so happy to collaborate work. Next, what we're going to do is turn it over to Dr. Cindy LaRouche, pull up her presentation, and I will do the introduction. So Cindy, as you may have heard, is an associate professor of several different departments. They all go over to you. And so your primary appointments in health services research and policy, is that correct?
Health services, also college systems, and
Very interesting. She is, among other things, an expert on, looking at the cost effectiveness of telemedicine, and I think that was one of the requests when we all got together at CMAR to talk about this and what is the evidence base here. So we need that. And before I do that, how's my sound? Can people hear me?
So, hi everybody, and thank you very, very much for inviting me. I want to let you know first off, in terms of qualifiers, that I am not a health economist. I work with some very talented health economists. So, in that case, what am I in terms of being here? So, one thing is when it comes to the telemedicine space, I'm kind of a prehistoric creature. And I used to say a dinosaur because I've been working in the space for about 20 years. The problem with using the word dinosaur is that they are extinct, and we do not want that to happen. So I needed to find another prehistoric creature. So I looked around and I thought, look at that, sea turtle. Now that sounds kind of interesting. So we're going to go with that kind of model. And when we look at what's happened with telemedicine, it's just kind of what's happened with the evolution of sea turtles along the way. We see some big systems, which technically telemedicine started out as telephone, right? Small, and then go really these big installations to carts and even mobile and various ways, shapes, and forms. Now, keeping with that thought of the turtle, is we often think that turtles make no sound. So I guess I'm here to speak with you today. Well, I looked up that fact. In fact, turtles do make sound. Some sound like electric motors, some sound like belching humans, and some bark like dogs, and some even cluck like chickens. And so I hope that I will not bark, cluck, belch, or any of those other things today, but that I can speak in an intelligent type of way. So starting off with moving into our discussion of cost effectiveness. In looking at the search of images for the current concept and term of cost effectiveness, it was interesting because I saw all these images of fighter pilots and all of that type of equipment and defense type of equipment, and then pictures like this one that's over to the right where we see the shaking hands and the charts in the background. And I thought, well, what does that have to say about cost effectiveness? And when I thought about it, is what are we trying to say? Basically, moving to new heights, and then we're happy about it along the way, pushing that envelope. In the course of this discussion, sometimes I like a story within a story, so I'll give you a little bit of a subplot as we go along. A recent study that we finished had to do with virtual urgent care, where basically you have the sniffles, the respiratory infection, and you're reaching out via video, telephone, what have you, to a virtual care provider. We did a qualitative landscape analysis. You might see the qualitative in numbers. What does that have to do with pulling it together? And I'll kind of make that link in terms of subplots at some point as we go along. But one thing that we're looking at in this context, has with many contexts with telemedicine, is that goal and that claim, that link, and but it's the right thing to do. And sometimes that pushes us from looking at the cost perspective about, well, it is the right thing to do, how do we make it make sense? And we always have to think about that right thing to do first. And in terms of sometimes thinking outside of the box, in some situations, there was one that comes to mind in particular where there was a telehealth system. It was just the right thing to do because it was in the center of the country and the markers were really just deplorable, and because of population. So sometimes we have to push beyond what's standard out there in terms of models and what have you. And I started to ask the question in that case about human benefit. Is there a way we can fit it in? And did some digging and found out that there was very little research and study in community benefit telemedicine. Can you fit it in? So just a statement that when there is something that's out there that's the right thing to do, when we're trying to make the numbers and things make sense, sometimes we have to think outside the box. So let's keep that in mind as we look towards the standard. So when we look at what's been done to date, and we look at literature, and here is, anybody wants to browse through, and I'm happy to pass this out, just a very informal lit review of what's out there, what's been written a long time. And what we see, and this is excerpts of little nuggets of those findings to date, you see green, and green, basically green text means like indications that there is some cost effectiveness, that there is some cost savings, that there is something out there that says that this has a good value proposition from that perspective. We do see some instances, and there's one in red, where in this mental health screening for military was that it was more expensive, but they have these qualifiers there that basically it was large numbers trying to push through the system in terms of a particular compressed point in time. So one question we have is, looking at this, it seems that when you look at the reports, if you would go through these pages that I've sent out and have to provide to people, you'll see a lot of, yeah, this makes sense. So it seems like, well, we should declare victory. Not exactly. One thing that even in those cases, and this has not been reported to my understanding, but as I was going through this, one thing that I started to see in some of these recordings was that there seemed to be a break-even or a throughput level where things make sense. And we don't have a lot of that conversation yet. It's kind of anecdotally mentioned in conclusion. So just first thing to kind of think about as you think about going forward, and I just pulled out some of the data from this study with ophthalmology, cardiovascular, diabetes, ICU, telestroke, where you do see some indication of there seems to be an optimal point. And even in that one case where it's in the red, it was indicated also in that same particular article, with that small number, it may make sense, but it was this large group in terms of a compressed amount of time. So can we declare victory? Well, no, in terms of when we look at the summaries and what have you, because what they're telling us is this is a cost-consequence matrix. Simple concept here, and I'll try to keep everything. If there are economists in the room, you will probably hate me because I'm oversimplifying everything, but I'm also a CPA for past life. So information systems CPA, multidisciplinary, so this is going to sound way too simple to you. But basically what we're trying to do when we talk about all this cost stuff is get in the green area, where we're basically saying that the benefits outweigh the cost, there's a little difference, that get in those green spaces. When we look at aggregating all the reports to date, what we really see where we are is the insufficient evidence types of spaces when we're pulling everything together. Now, how do we reconcile the situation where we have all these reports, these individual studies that say, oh, we're in good shape, but these other kind of, when you put it all together and try to do these reviews saying, well, it's inconsequential. And that's part of what I'll talk to you about, because that's what we really have to think about going forward. So where do we start? What does the literature say when we look at summaries? And there have been about 5 systematic reviews of telemedicine cost measures to date. What they're saying is that most of those studies, that they're pragmatic assessments, and that basically, there's a lot of detail we'll go through, but that they're adding poorly to the knowledge concerning costs and benefits of introducing telemedicine into clinical practice. And what we're going to really talk about the rest of the time I have with you is really understanding that statement as to why. What's going on, why. So let's start kind of at the beginning. This is a place, and having gone through and done evaluations with various types of systems, VA, large systems doing telestroke, telepathology, behavioral health, what have you, is this is something that you don't always see as a starting point. And this is a qualitative starting point, where we just sit around and basically say, what are the costs? And really think about the costs, not in a quantitative way yet, but in a qualitative way. What are those costs? And then what are the consequences? What are the consequences that we're looking for? What are those outcomes that we're really trying to achieve? Those outcomes are not going to be the same in every type of telemedicine service line. And that's something that we really have to understand. When we're trying to aggregate all this data, this is like trying to make a general statement about all forms of every specialty of medicine, saying, yes, it's all successful. There are nuances and there are differences in terms of what you're trying to receive. And so when you look at consequences, there's all kinds of things that you might be trying to do. You might be trying to achieve a situation where the patient is receiving treatment earlier than they would otherwise. You're maybe trying to achieve care equity, improve quality of service, transfer of skills. The person that's on the other side, on the spoke site, classic video conference type of situation. It might be education, more satisfied patients because of demand, all sorts of things. And once you have that qualitative sort of balance sheet that you work with, then there's other things where you start to think about where are some gaps in terms of the knowledge you have about those things. And also, not all of these things are going to be created equal for every situation. For example, there could be initiatives where at a global level, even a population level, we're trying to achieve care equity. Where other situations, that's not going to be weighted as high as to why you're doing this. So one problem that we see starting out is this is not necessarily where people start out when they're thinking about moving forward.
Care equity meaning, what does that mean?
If there's a disparity of care situation in terms of subpopulation groups, where certain subpopulations are not receiving care at the same level as other populations. And it could be a matter of locale. One classic example of that is sometimes a comparison between urban care and rural care. Thank you very much. And anytime anybody has a question along the way, happy to talk with you about it. So once we have that, and this is where we start to dig into that virtual urgent care, that situation where we can call and we've got the runny nose, the fever, what have you, or a video, and get some instant information. In terms of landscape analysis, looking at that benefit side, there were a lot of different reasons why different types of companies were going down this path of doing this virtual urgent care service. One was just to have convenient 24/7 care for patients. Additional provider capacity, that our providers, our primary care docs are just so busy that we really need to do this to extend the capacity of what we already have. To just have availability of service to the entire community, to have right-fitting care so patients are not going direct to the emergency room, that they are basically seeking something that is a less costly care earlier, where they don't need that big, everybody honing in and all the work that's done in emergency care. And offering to basically having another business proposition where we can do this, and for self-insured organizations that we can then basically become, we can have a service to them where we, for their self-insured, that we can provide them with something that they can do, and we can make money by charging self-insured types of organizations this line. Once you have that, here's kind of our overall, then the thought is, how do we start to get to numbers? And that's where we really start to think about, okay, if we've got convenient access, 24/7 access, what are we trying to do? And then drilling down at lower levels until we get to a point where we can find something that we can start to measure that makes sense in a measurement. And so I'll hold to you first off with some of these types of studies that are out there, is we're not always doing that. With starting out with what are we really trying to do? What are the top priorities that we're trying to achieve? And then starting there and saying, okay, let's backtrack into how do we start to measure those items. One other thing that we want to think about in this space is perspective. You can do, when you think about cost effectiveness or make sense, cost benefit, what have you, from whose perspective? Because some things may make perfect sense from a patient perspective. I don't have to travel, that costs me a lot of money, I don't have to take off of work. But from a provider perspective, perhaps it doesn't make sense when you're looking at the dollars spent. So we have to think of perspective. And if you want to look at this holistically, then we often have to do just that, look at it at a holistic level of everybody's perspective on, does this make sense from a dollars spent? With that too, when we're looking at the organizational side, and this is in our landscape type of study that we did, you think about, okay, well, let's look at it from the organization, right? Well, there's all different types of organizations that are out there. When we were doing this cross-country study, we talked to critical access hospitals, vendors, outside vendors that provide this particular service line that health systems contract with, overall health systems themselves, because something may make sense at an individual hospital or lower level, but at the Medicare practice level, does it make sense? Insurance company and third-party payer in general level, and also employers if you're that self-employed. And I'll hold that even within this organizational arrangement, not even looking at the same service line, the value proposition when you actually put the dollars to it doesn't always make sense for every single group. So having that broad picture and where do you sit from and that perspective that you're looking at, and even looking beyond this, looking at even a population, whether it be a certain county or area, it changes the way that you flavor and see these things. Then you have this world of, this is not one type of analysis. Now this is the part where economists will hate me because this is really watered down. And what I did was kind of list out in this analysis column all these types of analyses that you see. Project cost analysis, cost minimization analysis, cost effectiveness analysis, cost utility, ICIR to go with that, cost consequent analysis, cost benefit analysis. That's a lot of stuff and ways to basically run the numbers. And when you look at it, and I kind of oversimplified this by just saying, okay, let's look at what they're measuring in each case. In each of these cases, when you look at the cost side, generally they're talking about dollars. Dollars that are outlays or perhaps even missed opportunities. Where things get really differentiated, really muddy, and looking at all these different types of analysis that you do, is the outcome. What are we really looking at? In some cases, like the top two, you're not looking at outcomes at all. You're assuming the outcomes are going to be the same. For example, if you do this in person or if you do this different in a virtual space. So in that case, you're not even worried about outcomes. In cost effectiveness, classic with cost effectiveness, you might be looking at survival rates, life years gained, number of clinical events avoided. And then in the cost utility, you could be looking at basically improvements of quality of life. And it goes on from there in terms of that's where a lot of the variance comes in.
Can you kind of talk it out?
Sure.
Is there an accepted best one, and are there most common? And I've seen cost-effective analysis, and ICER is probably the most common, but I don't know, just depends.
It depends. And in terms of the best one and what you see, and when you look at these studies, and even I'll make this Excel schedule, it's crude, it was done, putting everything together available, you'll see all of the mentions.
Is it possible to have this, the same program, and by using different analyses, come to very different conclusions? Like say, your BCC program, if you use a cost minimization versus a cost consequence, is it possible you could say thumbs up, thumbs down?
Yes, and we will actually look at that because that can in fact happen because our benefits that we're looking at are different. So when you're looking at something, for example, in one way where you might be looking at critical events avoided versus years of basically quality of life gained, you might have, because the benefits are different, it's like anything else, it has multiple consequences. When we make choices in life in general, they have different consequences, and some of them can be very good consequences, some of them can be more challenging consequences.
So looking at this, and what I've been struggling with is we're at the beginning of telemedicine right now. So how do we then set up a way that we have a consistent measure throughout the state so that we can look at different communities by different things, query it, see that we have the ability to measure satisfaction of patients as well, their cost savings, and what we can do to reduce the cost for the carriers, et cetera.
Hold on, we'll get there.
Okay.
It's going to be, part of what I'm going to do in answer to that question is put it back to you, because I think that I'll give some kind of thoughts, and I think your thoughts that come into that in terms of coming up with that model going forward is actually a great activity for this particular committee. So let's take that a step further. In terms of outcomes, in terms of can we come up with a situation where we have a little bit of a mixed bag, and you sometimes see that even reported out. Well, we're looking at different things. We're looking at sometimes assume the same. And a lot of times when I've done evaluation, and I say, show me the numbers, show me what you've done, show me some of that preliminary work, I get a project budget. And I say, no, I'm looking at what happens once this goes live and downstream. And they look at me like just puzzled. Particularly in cases when there's a grant-funded project, that they're not looking beyond that grant fund and what happens when it runs out, maintaining going forward. So that's kind of an assume the same type of situation. Sometimes you'll have where people are trying to look for and actually reporting clinical outcome results, looking for actual financial, have we done anything to the bottom line? The quality quality of health and satisfaction. And you can have situations, and in other work that I do, is there are not that many studies you see, particularly from a patient side, where you see reports of patients not being satisfied. You just see the reports of satisfaction. You see clinicians being, oh, this is something extra sometimes, and those sorts of things. But in the cases, the sell to patients for many, this is a generalized statement, there's a lot of exceptions, but for most situations, you don't see that hurdle. But look at the difference in the types of measures we're talking about. So yes, it is very possible that you can have, depending on where you're looking, different results.
It reminds me of the quote by Mark Twain. It says, there's lies, damn lies, and then statistics.
And it depends on what you're looking at. And it comes back to what is it you're trying to achieve with that program, and then thinking about that balance sheet, weighting those objectives. Because your final victory might be what you weighed highly, and did you achieve that objective?
So since there are being more and more of these procedures through the Medicare program that are being paid for, are these type of analysis that you've laid out being done?
That's a very good question. Yes, no, consistently, not necessarily. You do have even some grant funders that have made the decision about at least get to the point where you don't just give us a project budget, show us that you've got a sustainable model. So I think we've gotten to a point for some national organizations, some funders, to at least say, show us how you're going to sustain this. Show us your version and your iteration of the financial value proposition or the value proposition here. But in terms of a standard type of model, to my knowledge, not yet in a lot of cases, in terms of here's exactly what we want to see. And that's something that could be something to ask for, saying, here's what we would like to see, here's what we're going for, and here's how we'd like to see it.
It's very spotty. I think telemedicine, if you look at it versus like cardiology or oncology, those fields way more cost benefit, cost effective.
And I realize I may be getting the cart before the horse in this instance, but if we're going to see this move ahead, at least in our state through the legislature, what we're going to have to do, I can guarantee carriers only look at the top 10 spots. But that's why I asked, because in some cases, Medicare is leading the way.
Sure.
By moving, okay, we're going to pay for these. That's why I asked if these analysis are being done to give a framework. And obviously, that's not the case.
Well, you know, we have a little bit of a cart before the horse and going back and forth, because in having conversations with CMS, the answer is give us the evidence. It's like, great, give us the reimbursement. And then it's like, give us the evidence, like, great, give us the funding to get the evidence. So what you see is that this is not a systematic review, but this is a concerted effort to give some of what's out there. And for the number of years that we have had telemedicine, that particular, those 4 pages or 6 pages, however many it is, should be at least quadruple or more of what you're seeing in terms of these types of studies. So they take time, they're intensive, and in terms of getting the evidence, it's this cycle. Somehow we've got to get on the bandwagon to turn that wheel so that we get the evidence to make the statements, and that's the accomplishing part. There's a philosophical decision that has to be made when you're looking at this, and this is the philosophical component, is telemedicine a method of providing the same service but in a different manner? Now, you talk about cardiology, you talk about these other things, and oftentimes you're talking about an intervention. Something is being created, something's new, a new drug, a new this, a new that. Well, is this really a process change, or is this really something that's going to lead to a direct health benefit? So I have this picture up here that shows a commute. People are riding on the bike, and some people may be taking a bus. They're still going to wind up at the same outcome. So do we have a basic process change? And what we are trying to do is take this process change and pull these health outcomes out of process change. And that's where a lot of these classic health economic measures are about, is the clinical change, the quality of life change. But what we're really talking about is the change of process. And should we really be looking at this from the efficiencies and gains from a process perspective, time, and what we're really trying to do, satisfaction and what have you. So that's why this concept, and I'll talk, overall now more about the benefit side than the cost side, because that's where a lot of the squishiness and the decision making has to come in. And this is a philosophical decision. It's a paradigm question. And it's one that to be debated and thought about, because it really does direct where you go and how you go in terms of approaching what we see. Because if you're demanding, tell me that we're going to move the health markers here, here, and here, and if this is fundamentally a process change, we're not quite in balance. Maybe downstream, by, for example, this morning I did some interviews, I asked the question, and it was not about, it was a different type of project, but if the patient would have had a treatment change for diabetes, complex diabetes, and if you were able to make that assessment 2 weeks early, can you tell me if that would have an effect on outcomes of care and clinical care? And the answer was, well, yeah, it could. And there was another interview I did today. It was the same type of thing. Yes, it could with the wound care. Yes, it could. If I can determine that this, in the wound care type of situation, that the person might have infection, and I get that early, does it make a difference? And that's something that's a really sticky thing in healthcare. And I am not an MD, but in those instances where, in terms of the health types of benefits, that's one reason I have this up there. Is one way of thinking about those health benefits is those situations where that getting to know the diagnosis or if a change is needed earlier in time. That one thing that I'll offer to you to think about is those might be the spaces to really look at to say this is where we can kind of really grab something in terms of those health benefits. Likewise, in terms of health benefits, is thinking about, and in terms of financial benefits, the other aspect of time, is how does this affect downstream cost and revenue? Does this open the gate where, and telestroke is a classic example, where we basically come in and we help somebody with administered TPA, particular drug, where that all of a sudden they're part of our system going forward. And classically, with a lot of these models, they have not considered the downstream potential of revenue. So 2 big time pieces as you think forward and how you're going to handle this. Here's a great example of that mixed bag situation from our study. So we had, this is not like this was just basically finding out from all these organizations, what do you think, where do things stand? So patient satisfaction with virtual urgent care, universally, everyone we talked about around the country, yes, we're having great information there. In terms of not administering antibiotics in an inappropriate way, yes, we're following all the standards there, that's good utilization, we're not where we want to be in terms of patients using the system. Web metrics indicate that patients are seeking this type of service in instances. No metrics on marketing dollars, service fit, meaning that coming here versus going to the ER, not looking at that, and also no metrics on service duplication. If they call urgent care, do they do something else and go to the doctor anyway? Now, I want to just point to you, because here's the danger and something you have to think about. First, utilization, and one objective is conversion to primary care. We're basically going to have people that call us up, our system provides this urgent care, and they're going to basically, they don't have a primary care doc, and they're going to be part of our system. Sometimes the issue is not that it's a telemedicine issue as to why that metric is not being met. When we dug in and asked about things, that we had process issues, where basically we were giving the names of patients that did not have primary care that said, yes, we would love to talk to somebody, and guess what? Our system was bogged up that no primary care docs were available in the next 3 months. So that's the reason they're calling in the first place. So is that really saying that telemedicine is not effective for giving you that downstream revenue, or does that say there's a workflow problem, or the handoff is not happening in the way it should? So even when I'm a big believer of mixed method studies, because even when you see these things, sometimes when you ask the why, it's not that what you're doing is off, it's that there's a problem in the workflow. There's a problem in the downstream in the process that we have to think about. Cost challenges, just quickly running through these because I think benefit is really where a lot of the fuzzy areas are just trying to get this type of information, all those types of costs that I mentioned, just digging that up, because it's not always just for telemedicine that you need them, but you often want to compare this to conventional care, right? So sometimes you can get this for the telemedicine side, but not the conventional care side to do those comparisons. It takes work, and this is where some of the work comes in with funding and everything else. There's also the situation that we have changing costs of technology, that we've gone from the big, mega, super expensive system to something that can be done on a mobile phone. Well, sometimes those changes are taking place while you're trying to figure out, and you know what? Something that made no cost sense, if I look at a study on certain types of telemedicine that is, say, 5 years old, and look at what they're doing now, it's not the same because the technology is totally different. So can we now take a retrospective study of the last 5 years with these different technologies and say, okay, this doesn't make sense. Well, wait a minute, we need to roll that forward because we're using different technology. Something else that's not done, and this is sort of an accounting nerdy type of kind of thing to say, but capital costs, is some of these things do involve an investment of equipment from the beginning of some sort. And oftentimes that's sort of this big lump cost. We've got to basically annualize that so it becomes running costs, so that you're looking at it on a year-by-year basis, so that you can say cost per patient, those sorts of things. And then the big thing is kind of alluding to and circling back with what I said earlier, we have to think about throughput, because there does seem to be hints of the literature that there is a certain point in time or a certain level where there could be economies of scale, if you want to call them that. So we have to think about numbers. We have to think about sensitivity analysis that starts to play with the level of service we're providing at different levels. And that, of course, involves situations where thinking about the number and level of staff required. Sometimes you don't need the MD doing everything all the time, and also changes in referral patterns that can happen. In terms of new costs that we see, one thing that we saw in our virtual urgent care study is that marketing is everything. This is a concept map of all the different types of marketing that people were doing, and you know what happened is the reports back is like when we were hitting this with the billboards at the football stadium for trying to get college students and doing this and doing that and doing the websites and doing the links, we were getting the traffic that we wanted. When we backed off of that in a big way, it wasn't happening. So that's not something you would normally think of for something to put in your budget, is this marketing cost and looking at costs. So just kind of looping back into, okay, collecting all of that data, all that systematic reviews, that's some of the things about the overall inconclusive is 4 or 5 systematic reviews have been done to date. As many reviews report both significant, non-significant, questionable results. And you see this sort of what type of results you're looking at, saving money, saving time, all of these sorts of things, and percentages of studies, they're reporting different things. And some report more than one thing, but they do report different things. So intrinsically, so what do we have going on pulling this together? The intrinsic nature of this telemedicine space that we're looking at, some of the problems with playing in this cost space, is there's a lot of fields. It's behavioral health all the way to telesurgery to dentistry to everything else. And it's very hard in any medical situation to say, we are cost effective in every form of medicine that we do. That's what you're trying to do if you just carry this all across the board. Technology changes. We're talking everything from sophisticated video to text messaging at times. Settings change in terms of where you're providing it. Sometimes it's home, sometimes it's clinic to clinic, sometimes it's hospital to hospital. We've got to think about that. Constantly changing technology, things become obsolete. Also is having that another intrinsic challenge is that empirical link, that direct link to that health outcome that we're looking for is hard. Goes back to that timing. Maybe we could do something that's saying, if we provide this care sooner. The extrinsic type of things that happen in terms of the nature of the studies themselves. Why did the systematic review say inconclusive? Well, we've got data access issues, few studies, small studies. Some of it's because of not being funded. The availability of administrative data, a lot of pilot projects. Pilot projects don't tell the same story as something that's been up and running for a while. A lot of these studies have less than 2 years worth of data. So that's some of the issues there. And then some study design issues where they have an ill-defined outcome. That comes up in every single systematic review, ill-defined outcomes. And I come back to that very first, where do we start? We need to think about what are those outcomes that we're trying to achieve. And not every type of telemedicine service line is going to be prioritizing the same outcome. There is increasing use of economic tools, but no general standard of health economic evaluations is specifically customized to the telemedicine context, because some of these things, like quality of life, they're indirect in terms of telemedicine, the things that really are customized, taking these great economic tools that are out there, but really customizing them to this particular space. And oftentimes they don't include indirect costs, and there are some indirect costs. This is just a look back that there are some, not many, but there are some guidelines. 2 studies, look at the years for this. 1997, 1998, in terms of guidelines for doing evaluations in this space, we've got work to do. And then in terms of just basic economic models, yes, we have economic models. care, and maybe we can take some things from these early studies and just try to take these economic models and start to basically customize to the telemedicine space. And there's just the general type of criteria that they use for guidelines. So looking forward, what do we do with this type of scenario? Well, one thing that we're doing as a next step, a next study, and this is being funded by a health industry academic alliance that I co-lead, called Center of Health Organization Transformation, that's partially funded by NSF, is one thing that we're doing as the next step, now that we have this qualitative information, is we're biting off that little piece and saying, let's look at some more aspects of downstream revenue in terms of this virtual urgent care. Does it, in fact, have a situation where we're not duplicating? Because we don't want to duplicate where they call, the patient calls, or does the telemedicine contact, and then goes to urgent care, or goes to emergency room, or goes to their primary care provider in an inappropriate way. So that's what we're doing. So things that you can think about, and this comes with what do we do? So things that I think that are ways to think about things, and even the systematic reviews have not done this to a great extent. There are some systematic reviews that basically look at specific service lines. We can't say that teledermatology or urgent care is the same thing as, I mean, we don't do that in other forms of medicine, so we can't do it here either. So basically kind of grouping those types of telemedicine, maybe we combine some types if they have some commonalities, but trying to say that, you know, the hands down across the board, everything is really hard to do. Thinking also about similar organizational settings in terms of the way that we group and look at past studies that are done. Like technology, you know, it's hard to say that we've done diabetes care using this sophisticated two-way video conferencing, and that equals something we're doing with MSF. So we've got to think about things like that. And also subdividing assessments by outcomes, because an outcome that's looking for something like improving disparity of care as a primary outcome, or looking at something where another type of outcome that you're looking for with earlier diagnoses, that we have to think about what happens when we're trying to achieve those types of outcomes. Because we can have victory with that patient satisfaction. In fact, that's one thing I think we can say across the board for most cases. But what about victory in some of these other types of outcomes we're looking at? Something else we have to look at, obviously strengthening the message, longer period of time, following study guidelines, all of those wonderful things we need to do, and customizing the instruments to this context. We have to consider the benefits carefully. I mean, that's been a message in terms of things I've said over and over. One thing that's been thought about in terms of analysis is doing what's called co-joint analysis. And what this means is basically where you present to patients or to providers, and particularly to patients, here's a basket of services that our health system provides. Here's another basket of services that our health system provides. One basket has telemedicine for one type of care, one basket does not. Which one? How do you value this one versus that one? And I think that's kind of an interesting way, this basket of services, to start thinking about things. More studies, absolutely. You know, we need more studies to declare success in particular areas. And then incorporating the economic evaluation at the beginning of trials. Sometimes these things are done prospectively, but then coming back at the end. Why? Well, cost change. So if we're doing everything prospectively, sometimes we find, did you ever have a budget and you thought, wow, I can do this, everything's going to be great, I'm going to have all this surplus? And even in your personal life, you're like, you've got plans for that surplus. And then you get to the end of like the month of the year, and there's no surplus because things cost more than you thought they would. Well, we've got to be careful about that. And with that, I would say, yes, we do need that perspective because we've got to think about the costs we're going to incur. But then also at the end, use updated costs, and then on top of that, think about even in our outcome sensitivity analysis, where what if we had higher throughput? What if we had throughput that wasn't quite as high? So start to think about where are those break-even points. So these are some things to leave with you to think about in terms of next steps. I think there's work to be done.
I have a question for you. So I would like to have the doctors paid exactly the same as face-to-face. But the carriers are not comfortable with that because we can't prove that it won't cost them more. Is there a methodology to look at what effect that may have on carriers? I know looking at it prospectively may not be the right way, but I'm looking at how can we start this and kind of hold them harmless in some way so that we could have time to prove that we could actually save them money and therefore the patients and protect them as well.
So I'll hold this up for a general question. I think that we do have to do that perspective analysis of what's moving forward. So that's the done that we have to do. And then we have to go in and say, okay, we will be making adjustments along the way. I mean, it's like with anything with estimating, with going forward, you do the best you can with the information you have, and a lot of times the devil's in the detail. So I think sometimes what happens is what I've seen is in that early stage, is earlier you talk, here's our overall objective, and really drilling down to a point where we can get something measurable and something that we can actually put numbers to. I think a lot of it is getting down to that detail level and running that detail through early. And I know you're the third party payer to the space, so adding on to that too is what would you like to see?
But we're in a little different situation for Medicaid because we are at parity. We recognize and acknowledge that. But I think, in a pilot environment where you can, test models, it certainly offers the safety and security of let's try it, let's see what works. And you got to put your stake in the ground somewhere and say, this is where starting, but we may be wrong, but there's no harm, no foul because we're not, implementing this on a widespread basis to your entire membership. You're piloting, and that's how we started our telemedicine program for virtual care as well. With one institution, started very small, and then expanded it from there.
And I'd like to add something to that. I think what does not happen in the pilot is it's that last side, they leave the information at the pilot level and then don't do the sensitivity analysis after and actually put the economic models after to say what does happen when we scale up, and let's do the what if scenarios in terms of the changes in throughput, even in terms of that pilot. And that's something I would track through with the pilot. You're going to start slow. And so even in the pilot is break up that data collection to see where you are in throughput and what's happening with cost throughput. So prospectively, but really watch that pilot closely, particularly when you start to change throughput, because I think there's an insight that you can gain there too, extrapolate out.
You have a very interesting perspective coming at it from the business model side and also from the outcome side. I think what people don't often appreciate is data collection and studies are so intensive and so manual. To incorporate them into electronic medical records and get the resource of the quality that you need to do that kind of a study is very, very challenging. And I just want to come back to your comment about providers. For us, payment parity is often a barrier to entry into telemedicine for providers because the first question they have is, can I get paid? Well, kind of, sort of, at this level. That's a stopping point for many of them. So I guess you really have to focus on, is my goal looking at outcomes and making a change, taking a pilot project to a much larger concept, and developing a business plan that scales and all that sort of things. Where do you start and what's your target? We're just thinking about approaching Medicare with a request to add some new codes, and they want data. That's all they want is data. And it's quite a process to start collecting that data on a large scale with a large number of health systems that want to be a part of that ask. And so, where do you start?
So we have the all-payer claims database. Could we not look at, and this is what I've been, thinking about, could we not look at utilizing that all-payer claims database more broadly than what we're doing right now? I mean, we're gathering all the information that's on a HIPAA, which is basically everything for that visit. But could we not then extrapolate from that database anything to do with diabetes, et cetera, and it's all in the query in that, from my perspective on that, and then start from, how can we broaden that all-payer claims database that we've already started?
Well, yes, and I'll tell you too at this stage is that looking at telemedicine, kind of the area that I've looked at telemedicine in the business side from the start, and I'm an anomaly because that's not where a lot of the research is. And so you don't have, and I have to reach out and find health economists and what have you, great people that I work with. And there's not enough people looking at these types of issues and even trying to have their data. Even for the study that I mentioned that we're doing, is we're really, pounding the pavement to get not just one health system, but multiple health systems that we need together to look at that downstream, what happens downstream.
that's how we have to look at it going to Medicare, because we have to prove outcomes, but we have to know that this is a no-cost gain, or it won't even be considered. So what are the cost savings potentials to this? So it's complicated.
Senator, are you thinking about picking one ailment?
One modality? So
one thing and
so
trying to do that, or?
I'm actually been toying with, we have an opioid problem. And so I like my whiteboard and I draw all these things out, but if we utilize Project Echo and got information out into the communities, and got provided the trainer or the doctors with more information, or the PAs, et cetera, community health workers, and we're working on some definitions there. But we get that information out, and then opioid addictions, I'm looking at diabetes as a real huge issue, and then looking to you guys for whatever, but maybe limit it to 4 areas, so that we could say, insurance carrier in these 4 areas, this is what we propose, so that we're not throwing the whole bailiwick at them at once.
Well, when I started looking into this, I went and interviewed all the hospitals around my area. And the one area I'd like to throw into that is the telepsych.
Oh, we have to, yeah.
I think that's an area, because there was a pilot that ran for a while, and every one of my hospitals that did that said we missed it. When the money ran out, we quit, and it stopped. But the results they had from that, I mean, they were asking if that is an area where we really need to see. And if we're going to pick and choose just a few, I would hope that might be one that, because I don't see how, from what you laid out, unless we start with just a couple things, I don't see how this moves ahead as well as it can. If we pick some small areas, have some success, can track the data to move ahead. I mean, I'd like to do the whole thing, but I don't think it's going to happen.
I very much agree with you, and that's in the first one about subdivide those assessments, is really look at it from that subdividing perspective. Where are the priorities? Where can we really see? And I think that what can happen is Washington's often has been a leader in various ways in healthcare, but you have to get that case or those cases, a few cases along the way, and then, others start to follow and say, okay, now there's a model in place. We've done this for check the box for this area. And really that's the way telemedicine evolved in terms of service lines. We have a plethora of service lines that exist right now, everything across the board. But at the beginning, it started with just some very specific things, radiology, dermatology, those sorts of things, and then it's expanded out now. Well, maybe to kind of really get a solid foothold in this space, we need to take that same approach. Let's start with a few spaces. Let's do it right. Let's have the bigger type studies, and then we'll have all the different modalities come on thereafter to see what's going on in that space.
So are we talking about possibly a study to demonstrate the value and the cost effectiveness for payer discussions, or what are we talking about here?
That multiple perspective is, if you don't have if you have just the payer, you also need the patient perspective to really have the full picture. So I think those specific areas are the full picture.
I think, one of the challenges that we're seeing on the payer side is utilization and uptake. And so the same challenge that Denny just shared about how doctors are not interested in participating unless they get paid the same, you have a kind of a counter challenge on the consumer side that unless you make it cheaper for them, they're not willing to try it either. And you can see this from the pricing that's set forth from like all of the clinics in this room here. You price your telehealth visits at like $25 to $35 a visit to the public. And so, and Dr. Scott and I were kind of changing emails on this piece, is you have to set that price, because unless the price is a lot cheaper than an in-person visit, the patient isn't going to try it. And so there's these, you have these all these pressures and forces that are trying to be balanced. So exactly from the consumer side, making them want to try it as well, there's kind of that pressure to lower the price for that, at least initially,
It depends
right?
on the patient side too, because it is the awareness that's there, and it's the marketing that's there. So it's, all of those pieces come into play too, because if there's no marketing and awareness, then you're gonna have that problem too. But I think picking off the fruit, where you wanna go first in those areas and those types of organizations. So that's really all that I had to say, and the only thing that I was gonna leave you with is coming back to the turtle, is basically, is that, and on the very last slide there, is that one thing is just like, okay, I need to make a link between turtles and telemedicine. So turtles live all over the world, and they've even been in space, and so telemedicine exists all over the world, and it has even been in space, and they're a little slow, and obviously, that's one big punchline here. We are, when it comes to this type of work and study, we are so slow in what's been happening in terms of cost effectiveness and what have you, but we're hopefully still in the race. And so I think that making these types of decisions about where do we go and just pulling off a chunk along the way, we've got to kind of move ahead and keep moving ahead.
So one caveat, turtles are slow on land, but they're fast in the water. And we need to get them in the water, this in the water.
Get them in the water.
Can I just read some of the comments that are coming through? So from Michael Matthews at Amtrak, he had a question whether this group is working with CTEL and the Telehealth Reimbursement Coalition. The research aims are nearly identical, and it's truly a national effort involving academia and vendors. So Mike, as you know, I know University of Washington is part of that. I'm not sure if Providence or
I think we're going to be
Multicare, some of you others who are.
We're going to be.
Yeah. So, but I don't think we have formally as a group reached out to CTEL. It might be good in the future to get an update of what CTEL is and what they're working on. Another comment from Joel Fossey is that there are large health systems on the East Coast that have proven models, and they have some data on their efficiency and effectiveness and the financial feasibility of these outcomes. And it might be a good idea to reach out to these guys and then to push that data to CMS and other payers. Let me just see if there's any other comments from the network, from folks on the phone or from on video who wanted to chime in on the discussion. Unmute your mic. So, Cindy, any other things, advice you'd give for us in terms of next steps? I think you've left us with as many questions, which is always great.
Yeah, I would say that thinking about exactly what we talked about here is picking that area and try not to have that universal victory, but picking those areas and priorities. And underneath that is kind of following that model, is picking up what are you really trying to achieve in those areas, and then coming back to how can we measure those benefit achievements. Benefits is the buggy space. You know, we can find ways to get those costs, but really thinking through the benefit side.
That was a great presentation. Thank you.
Thank you, really good, thank you.
Very good.
So what our comment is in the prior discussion around the parity question. So I straddled it both roles, right, as a clinician, but also representing KB Washington as our own payer. And I guess the challenge for me is thinking about, I think what you represented earlier, that it's sort of feast or famine historically held. Some pilots you get paid if you do it, and then there's nothing. And people stop, right? And I get that. You're going to pay people zero, they're not going to do it. But I think the other extreme is parity. There's a lot in between, which is I think value, right? I think that's what we're all kind of wanting to know and struggle with, is where that in between. It's not zero. Personally, I think it's not parity either. I think it's somewhere in the middle around. I can tell you an example within KP where we have been telehealth for many years. We've done our own internal studies, including say what's the effectiveness of that. And about 30% of the telehealth visits never see a dermatologist anyway. And so, you know, if I were to pay my docs on a unit basis, I would probably get them 70% for that visit because I know they're going to come back and see them anyway. But they're all paid on salary, so it doesn't really matter. But they get more throughput. They see 60% more patients virtually than face to face. So I pay them the same. Why do they do that? Well, they actually like it. They get to work from home. It's more interesting. It kind of breaks up their day. There's other reasons that I think if I were on a human model and were to pay them and I said this is worth 70% normal business, I think they would think that's fine. So I think there's a realm between zero and parity, which is the sweet spot. And I think, you know, what's that
think, in my conversations last year with the carriers, they were willing to look at this if facility fees were gone, because that's a real cost driver for them. And so I think that's something that we have to take a look at. But I've changing a little, but getting back to this in some way is I had the opportunity to go to Sioux Falls, South Dakota, on a NCSL task force in the healthcare that I'm on, and we did a visit to the Avera program and the cost savings and the patient outcomes that they have in their ICU, their long-term care, and that's already demonstrated. And I am hopeful that I can get some of the true facts and figures and maybe look at, ICUs as one of those places. But I do think I don't want to lose sight of the fact that I really want care out in the rural communities. And that is your primary care doctor with extra knowledge and your PA, et cetera. So that's what gets hard when you're talking this huge global picture. How do you bring it in and yet meet all of that?
Well, kind of my closing message is pick that area you want to look at and go broad, because these types of process, and not disregarding the process, but this is a process improvement. Even if you're looking at clinical outcomes, you're still talking about process. And when you have a satisfied doc that they're not turning over, and the cost associated with that, talk about indirect costs, and you can keep them, that's dollars. And you don't see that in some of the numbers a lot of times.
I think that's another guardrail that's not reasonable in my mind, is thinking about ICU or tele-ICU or telestroke care. Those were several of the articles to start with were in that slice, because I think in those cases, utilization is an issue, right? Patients clearly need an intensive or a neurologist. There's no question, it doesn't matter how you're going to provide it in a cost-effective way or in a way that it can be provided in other geographies. So I think those are great ways to start. I worry more in areas where it's more of the direct patient marketing, and you can create some conscious where people will.
Well, the marketing part, I was
Bring people in
kind
with
of
low overhead
smiling.
and the same building, and that's.
I was smiling on the marketing because in one of my past lives, I was a manager for a obesity clinic, and we spent $10,000 a month in marketing. And if we dropped off on that marketing, we could see that reduction. And so it is something that I think that we're going to have to, because people don't know that they can do this. They're learning about teledoc. But, what we're trying to find out is if you have a teledoc visit, is it being applied to your deductible? Is there some, because otherwise that's just a pass-through for the carriers, and you don't want that either. I mean, the patient has to benefit from something of
Well,
this.
there has to be a sweet spot where the carrier sees the value, the patient sees the value.
Right.
Or it's just, how do we identify that to get to that place there? Because I get the carrier's position, but I also know good and well the access to care in a lot of areas is not as good as it could be.
I know you need to catch up, Terry, so.
Thank you very much.
Thank you so much. That was really great. So what I want to put a pause on the parity discussion, because that is on the agenda, but I do want to make sure that folks have a chance to look at the report to the legislature, because I have sent a rough draft in, just so you know, but I would like to send a final draft that as many members as possible have a chance to review it. And I'm going to pull it up here. While I'm doing that, I was fortunate to have several members of the collaborative be editors. So Sheila and Brody were kind enough to read it. And I don't think you have their comments, but I'm going to give you guys an opportunity to maybe just say there's certain areas where you wanted to maybe add or change or things. So I'll let you guys go first, and then let other folks chime in where they think things need to be changed. Sheila and Brody?
I didn't bring the edited version that I had.
Oh, yeah.
So I'll go off of memory, see how well that works. Probably not very well. Part of the suggestions that I had for
Here's the.
oh, great, thank you. Appreciate that. Really, from my perspective, one of the things I thought would be helpful is a little bit more documentation requirements, because when we get back to reimbursement, it all seems to come back to the documentation. If it's not documented, it didn't happen. So a couple of places where I've made suggestions, like on page 8, when it starts off with billing for telehealth, including documentation and billing. And again, kind of going back to, you know, historically, that's one of the biggest issues for healthcare organizations, and being able to keep what they have billed is if their documentation supports it. And I think that that's one of the really important things too, as we move forward, is making sure that we're providing some guidance what needs to be included in the documentation, since a lot of the providers who are doing telemedicine right now aren't billing for it. And that's a big deal for, and I'll defer to the providers in the room, but I'm sure that you've had coding auditors look at your documentation and have provided some feedback. And so I think that that's one thing too we don't want to miss in this, because that's a big issue. So really on page 8.
Can I expand upon your thought on that? On the training portion of it? I think we should develop training requirements before providers can provide telemedicine services, so that they have the actual real truths. There's bills out this year again on the pre-files that are looking for fraud and abuse on docs, and we just can't have
So when Denny and I talked about the training, speaking as a representative of a large institution, you cannot even start to see people through telemedicine unless you've got a separate privilege. And as part of that, you have to sit through an hour that I'm going to bore people through.
So can we tie that into the ECHO project?
But I just worry about, Senator Becker, my concern is, what about those smaller practices that they don't have?
Well, that's why I was thinking ECHO.
Yeah, that's, or is there something else that's more online out there? I'm looking at
Like the ATA guidelines.
ATA guidelines. They're pretty, the thing about the ATA guidelines is they're really dry. And how do you bring those to actual, the context of Washington State?
Well, you also have to remember that providers that are eligible to provide services may not be MDs, DOs only. There's going to be multiple different levels, and they need to have that training.
Then we get into
the liability part.
Well, the agencies that oversee those, let's say, physical therapists, and it's not in their scope of practice. Should they be doing it anyway?
Agreed.
So I don't know if we can try and regulate somebody that's not supposed to be doing it in the first place.
What we were looking at is looking at those that are identified under our CW, and I can't remember I think there's 31 professions under that, but we can get that information to you.
Well, and I think that's actually trying to be referenced on page 7 about the compliance and fraud prevention in telemedicine. Because again, one of my suggestions was maintaining compliant documentation, coding, billing, and other practices. And further down, there's a link. And if I remember correctly, I think that link kind of identifies some of the documentation requirements that are needed for a telehealth visit, the CMS guidelines. So I think those are probably the, just kind of from a theme perspective, was really trying to take a look at making sure that we included the importance of the documentation, because the billing is all based in the documentation, but we can't forget that the documentation is critically important. You've got your documentation, then your coding, and then your billing. So that's what I made a couple suggestions.
Yeah, I like.
Thank you. Brody, do you want to
Yeah, I just had small edits. I think the ones just to call out was there was a comment on the bottom of page 5 that referenced about how says the program, this is the e-consult, is not currently reimbursed by any payers. I know that we have it in our reimbursement policy to reimburse e-consult, so I just changed it to
all payers,
reimbursed by all payers. So that's kind of a small item. On page,
where are you on that?
Page 5. It's kind of hard. I could point to it on a page. It's like this
right
part
there.
of the page. There's just a statement that says the program is not currently reimbursed by any payers. I just edited it to it's not reimbursed by all payers, because
I think we say that about, remote monitoring too, that it's, because I know Medicare covers remote monitoring indirectly.
Yeah, it was bundled and then they've unbundled it. I think we're still trying to make heads or tails of what exactly is in that space. My second comment was related to remote monitoring on page 6 and 7. Underneath the picture of the baby, there is that paragraph. There was that sentence says, many of these are not FDA approved. However, there are a host of issues to consider with remote monitoring apps, such as medical legal responsibility, documentation requirements. I also added here, one of the interesting, unique challenges with remote patient monitoring is if they actually do have to pay for those services separate, that now we start entering into a world where is the patient aware that they're actually getting billed for this piece? Because let's say that to be monitored, their health plan is now paying like $50, $60, $70, $80 a month on their behalf. For those that have like a deductible or those that have like a copay, so even for those that have a $20 copay, they're going to start seeing bills for $20 a month as people are reviewing them. So I added some comments about is there anything about patient consent that they're actually being monitored? Because the doctor may give them a scale or a device and say, hey, use this, but they may not tell them that. And by the way, this is going to cost you something every month for me to read this data. And so I just kind of added some thoughts on that. And then the last comment was just related to the comment that I made for the payment parity piece, is that there is the dynamic that in order to get consumers to use it, yes, marketing works, but what is in that marketing? Oftentimes the marketing is, and this is way cheaper than your in-person visit. And so part of balancing, understanding that doctors need to be reimbursed for the work that they're doing, but at the same time, there's the pressure from how do you get people to even try it in the first place? It's usually by giving it at a lower price. And one of the things is, I'm assuming this is fairly common in the industry, but health plans pay the lower of the billed charge amount versus the contracted amount. And so if clinics are charging $25, $30 out in the public, there's an expectation that that charge is the same no matter who the payer is. And so therefore, even if we had payment parity where, we actually made the rate the same, the fact is the charge should be coming in at $25, $30, but that's what the publicly advertised rate is out in the market. And so it was just calling out some of those other dynamics associated with
That's really interesting, because you're supposed to charge everyone the same thing for everything.
Yeah.
That is
Medicare started all of that.
Yeah.
So you weren't differentially charging people.
But you are in telemedicine then, by offering it right
Well,
now.
the provider charge is different than the contracted reimbursement.
I understand that, yeah.
So.
Thanks, Brody and Sheila. Other comments or questions about the report?
Did you want to talk about the billing section, or did you want me to take that offline? Because there's quite a bit of detail in there.
Okay. Are there maybe broad concepts there, Danny, that you wanted to address?
I think there's some gaps in each of the sections, like the Medicaid, the eligible locations, and in the Medicare, there's eligible locations and providers missing. And I can give you those instead of.
Yeah, if you can just send me your edits.
Yeah, I think I did, didn't I? I don't know if I CC'd you.
You probably.
I'll send them to you.
All right.
So this is, so the folks are trying to follow along at home, page 8, under the billing for telehealth services. Danny was just saying, there's a couple of additional details he's kind of put in there.
And then we discovered when we were reviewing the Medicaid information that the last statement on their provider guide said, if you use the GT modifier, your claim will be kicked out.
And this is on the Medicaid.
Yeah.
And this so we put out.
Yeah, we'll have to contact them. It's I can show it to you. Yeah.
So maybe I can ask Senator Becker and Senator Schmidt is this going to be something that's useful to the legislators to review? And I tried to put a summary document up front and some use cases.
I think it is, but may I ask a couple questions
Sure.
on when I was looking at this? And I had, Alicia and I were sitting having lunch going over this, and on page 6, can you go through table 1? I mean, I thought I was pretty good on RVUs and whatnot, but this is confusing as heck to me.
Okay. So this is data that I was able to pull from the University of California, San Francisco. And maybe just look at the middle 2 columns of the charge and the RVU. So it's based on the 9944 codes. And they are charging one of their payers, I think, between $54 and $200 for those e-consults. But they also need to do some tracking internally, so that, like, for these doctors who are offline, they're not seeing patients. The way that we track our productivity is called a relative value unit, or RVU. And the point of that last column, and that's probably where you got confused, is I just wanted to make a comparison of what's an RVU if that doctor was in clinic seeing actual patients.
So it's a face-to-face versus.
Yeah. So basically I was saying, okay, if a doctor is spending 5 to 10 minutes doing e-consult, he would get credited 0.42 of an RVU. If he was doing a very short in-person visit, he would get 0.93. So going back to, I think it was Denny, your point is that, okay, I'm a doctor and I'm expected to have certain RVU targets. I'm going to try to do that in as short amount of time as possible, right? Because I want to go home and see my family, right? So when they're not getting as much RVU credit for the same amount of time, it makes it less attractive.
Oh, I see. I
Yeah,
understand it now. So
and
you're using your RVUs for productivity.
Right.
Okay.
That's our currency. As providers, that's our currency, and how we're kind of kept track of if we're doing a good job or not.
So consider your audience. Who are you trying to, who's going to read this? That explanation that you just gave, even though I
take this out.
Yeah, right. This is more confusing because people are not, I understand, but people are not gonna know what are you talking about?
Yeah, I think the point is, this is where telemedicine is going. And if the story in here is about the evolution.
If you could do this verbally though, versus talking about showing this, because I'm fairly familiar, to say the least, with RVUs, and all of a sudden I'm over here antitrust, and so if you're, you'll have to. I think a simple statement is we need to something to the effect of because we're paid differently, we're being measured differently. This, with telemedicine, we're trying to figure out how to make it work into the future.
What I got out of the message was this is about efficiency for physicians, and efficiency leads to bigger things with your time. And so if I can be compensated for being more efficient and do more, that's really how I can impact my practice.
But a statement like that is much more understandable
than this.
Yeah.
RVUs.
Yeah.
I debated taking that out. Help me solve that.
This is Joelle. I don't know if you can hear me. I put myself on mute a little while ago and then I couldn't figure out how to unmute. Can you hear me okay?
Yeah, go ahead, Joelle.
Okay. So I was in the health policy meeting yesterday that Senator Becker and Representative Schmick were talking in, and there was a representative from a payer that brought up a decent point, and Senator Becker, I thought, handled it very well. But it really generated a lot of thought as it relates to one of the clinics that I started a few years ago, telehealth clinics. And that is, we have health provider shortage areas like the district where Senator Becker resides and represents. And we think sort of typically about delivering services to those areas that just don't have resources. But and there are consequences if we don't get those resources to people. But there are also consequences even when people do have resources, but we're not getting them the health care that they need from a primary prevention standpoint. So we're often thinking about, oh, I have, a bloated belly and I need to see a GI specialist that doesn't live in my area. But what about, and that's more sort of secondary, tertiary approach to medicine. But when we're circling back around and talking about costs and considering how we can create a compelling argument that these services are warranted, I think thinking about that primary prevention as well, meaning the consequences if we don't work on even preventing disease, such as diabetes care that can land in really devastating illnesses. And I know this seems like a very circuitous route here, but what I'm wondering is, if people are really reading this document and we're launching into these dry sort of conversations about reimbursement, and we're really trying to drive home some foundational knowledge around reimbursement, parity of payment, discussions about how to make this a financially feasible approach to clinical care, I think that we're missing a mark if we don't include at least some language around how do we create a healthier population. We know that the health of mankind is worse in rural areas, and it's not all just about how do we get telehealth out there, but it's more about how do we do right by these communities by preventing disease from a primary perspective. And we know that there's a lot of data out there. So I have thoughts on how we get data. And I'm on a national AMA collaborative where there are 15 robust people who are working in huge health systems across the nation. And there's got to be data sitting there that an actuary or a healthcare economist could look at, and we could distill billing models and figure out what ends up paying and what that cutoff and that critical threshold is in terms of size of programs. But I also think we need to band together across the US and start solving the problem of thinking about not just the hardcore numbers, but what does the health of our population look like? And what does that look longitudinally? And so, the data is there. We just need to look at it. And we need to find ways to do it. And so when I listen to people talk across the country, I realize that actually many people in other states are ahead of where we're at. Many of them hold a pot of gold in terms of data that if we could band together and somehow leverage the resources in some grant money funding healthcare economists that could dig through some data and say, let's compare two populations. We have people who got care and people who didn't. Preventive care and wellness care, and then care to treat problems, and present that to our payers. And I know we have payers at the table today, and I'm sensitive to that, and I'm glad that we're all in it together. But it's not all about the finances of what the check was right out of Premera today for that visit, and sort of this unwillingness to pay up front when maybe they're not really considering what the financial consequences are down the road if they don't pay for that visit, or if we don't find a way to maintain people's wellness. And I know I'm preaching to the choir, but we spent a lot of time on this collaborative, and most of us have all been here since the beginning of the collaborative time. And I think we have to if we're really serious about making an impact, we have to reach outside of our room and maybe even outside of our state to find the resources. I know an incredible healthcare economist that I've worked with in the oncology world, and his background is in public health, and he loves this stuff. But I think we have more resources, and we should consider pulling people into this. I just don't know if our approach is going to create impact. And I'm curious if there's anything else we could potentially add to this report in the spirit of what I've just discussed that can be more compelling and drive people's hearts and minds in the direction that we're hoping for as it relates to payment parity.
I just want to make sure that something that you said made me think that you were saying something else. So I just want to make sure, when we talk about parity, there's parity in coverage, right? And then there's parity in reimbursement. And I believe for the most part, coverage parity is here. Like, I know that.
We're good there.
Yeah, so when we're talking about not paying for things, I just wanted to make sure that we weren't talking about not covering health. So anything that can be done both in person and through virtual means, we cover that, right? And so really, what we're talking about is equal payment for it. And I think part of the debate is, I can tell you that on behalf of our company, we definitely see value in virtual care and telehealth. We believe that for every telehealth visit that replaces another place of service, that there is value there. There's no one that debates that. I think really coming to what you were sharing, what is that price that kind of gets us to that place? And here you're seeing through the RVs, even though it probably won't remain in that table, it's showing that roughly it's 50% of the price. And so what is that price? Because I can tell you that much of the value that we share with the employers that purchase our health plan is that this is a lower cost option. So part of the value of telehealth is the fact that it's lower cost. And exactly how much lower cost it should be, as you were saying, I mean, it's kind of what the discussion is, but understanding, the setting. No one's debating that the work portion of the RVU, that the doctor is doing the work, that generally speaking, I mean, that's the same amount of work. But when it comes to the cost of the brick and mortar that's needed to play, I mean, there is that piece of it. And I know a good point is it obviously costs money to invest into a platform to be able to work from home. And so we recognize that there's no component, but I think just understanding that I don't think anyone's trying to devalue the amount of work that the doctor is putting in, but there are other components to telehealth that it's reimbursing that have nothing to do with the amount of time and effort that the doctor, him or herself, is actually putting into the business.
Well, and one thing you need to consider is that in reality, at least for those of us seeing patients in the clinical setting, you can't see as many patients on a typical clinical day when you're turning over telehealth clinics. You can see, I mean, I'd be curious what Dr. Scott's assessment is, but my experience developing, implementing, operationalizing, and being the clinician in those clinics, having practiced for 20 years as a nurse practitioner, so I can be quite efficient. Your efficiency cuts down dramatically. And I would say that I can, on a good day, see 75% of the volume that I can see in a telehealth, in a regular clinic. Some of that is because it's not like you have 3 telehealth carts beamed up in 3 different rooms and I can just step out of one room and the next room is queued up. There's a lot of inefficiencies and it does take added manpower. So, and I'm not trying to create arguments. I'm trying to generate thought, inspiration, enthusiasm to think outside of the box and figure out how we can continue to lead the way. I think we've done a lot of foundational work here, but, I am bumping into a lot of argument out there around having equitable payment, reimbursement, if you will, for visits in telehealth, which, arguably, it's more expensive and I don't know, I don't understand what the question is, but if we need to find more data, then let's reach out and I'm happy to lead the way on that because I believe that it's there. We just need to loop other people in. And I just don't know if we have that data in our state because we don't have the volumes under our belts.
Just for kind of keeping us on track, are we okay transitioning to talk about parity? We're already kind of doing that because we're doing this.
Sorry.
I feel like we keep on bumping into it. I'm like,
Before that, housekeeping. For me on page 5, it may not be a big deal, but the statement about us to e-consult. So we're migrating to e-consult from a homegrown tool. I don't know if it matters. Okay. It's the same concept. We call them virtual consults. Maybe it's worth mentioning, but we're not fully yet transitioned to e-consult tool, but we're getting there and we'll be this year. At the bottom of the 4th paragraph, Kaiser's credit e-consult 0.25 RVUs. It's actually a 25% value.
Oh, okay, so 25%. Yeah.
So we track new visits as concurrency within Kaiser, in Kaiser works, right? Is it? Okay. Not an RVU. Okay. And then middle of that paragraph says 50% of specialty consults are done by a consult. I don't know where that came from. I don't think it's 50%. We do about 40,000 a year. You could say that. Okay. I'm not sure it's 50% of our consults. Okay. Thank you. Thank you for that.
If I could make a comment on the report, I do think that Dr. LaRouge was really talking about something that this is your marketing piece. And think of it as this is how I need to market what we've been doing to the legislative body so that they get excited. I think she was spot on. And I think I like when you talk about the patient visits in here, the patient stories. But if you really look at the medical field, you know, in Medicaid, I had to write a bill to get the report on how many preventive services and immunizations were being done in the managed care and the Medicaid, because we used to be able to get to that, but we couldn't get to it anymore. And if we could talk about, this has the potential for the, you know, once you've had your preventive services, you know, finding things earlier and being able to follow those and treat those earlier is going to save lives. And that's what we've heard about for years, and that's going to trigger some things with some of the members of the committee. And what are some of those trigger points, you know, making Washingtonians healthier, but being able to get to that information and showing that it's actually happening because of telemedicine services and reaching out to Eatonville, for example, in mental health. It's been really great for the Medicaid folks, but it's doing nothing. When you look at, and what I talked about yesterday is there's 1.9 million people on Medicaid in Washington State, but there's over 7.75 million people in the state, and we don't know what's happening with them. Whether they're on an ERISA plan, you know, a self-insured plan, or whether they're on a commercial, we don't know.
The other thing I think is a little bit invisible is the depth of telemedicine that's going on in the state already. Maybe we should figure out a way to, at some point, maybe not this report, but talk about all the things that are already happening out there.
We did that initial, that was in last year's report. Remember, we did that inventory.
I'm sorry.
But I mean, maybe it's a good reminder of saying there are already, you know, 200 plus programs out there or whatever.
And we're excited about those 200 plus programs that, you know.
Yeah, they're great. Putting numbers on that. Okay. All right, so we ready to go on to parity full bore now? Okay. So I was really appreciative of the articles that Danny had forwarded, that I think did a real good summary of kind of pros and cons. So there's one about Kansas and how they had a failed telehealth bill for payment parity. It was news to me that there's only 3 states that actually have payment parity. It's Minnesota, Delaware, and Hawaii. So the way I think about this is that we're all looking for value. And what is the equation of value? Value equals quality of care minus the cost. And I think where there are, we have some misunderstandings or disagreements on both of those things. So when I was reading this article, I heard that a telemedicine visit is not the same as an in-person visit. And as a clinician, I would really feel badly to provide substandard care, whether in any kind of case. So at UW anyways, I can say that we will never, ever do anything that is substandard. So if I need to look in your ear, we're going to stop the visit and we're going to find someone to look in your ear. So I was just kind of push back on that quality, and we actually have really good data from patients themselves saying how they value this. And then the cost, I just wanted to elaborate on what Joelle was saying about there's definitely some issues with efficiency. So my clinic this morning, I saw 10 patients. I had 2 rooms going, and I had, you know, I was bopping in between them. I had one patient who the nurse needed to do something, and I could go and see the next patient. I can't do that with telemedicine. I gotta hang out there. So just a point about that. The
the technology is kind of expensive. Just to give you an idea, an e-stethoscope is $1,500. Whereas I can get a really good Littman too for like $200. So that's just one small example of how sometimes the equipment can be quite a bit more. But I want to figure out a way that we can maybe get beyond this, because it seems like it's a cart and horse thing, that my clinical colleagues, they won't do it unless they say I can do the same, because there's no incentive. I have a full waiting room, and I know I can guarantee that I'm going to get paid for those people. So I'm just going to lay that out there, and then maybe we can see if there's a way to kind of, I don't know, it sounds like Senator Becker, you were talking about some kind of a pilot, or
I'd just like to make a suggestion. In having some discussions with ATA policy director who did a lot of this work on it, I hope that we don't try and reinvent the wheel, but let's learn from the states that were successful, those 3 states that already did this, and let's figure out how they tackled the obstacles that got in their way. Because what I'm hearing from them is it's all about language in the bill. It can't be too restrictive and it can't be too open. It has to be specific. And I can see why that's an issue for the payers, but I'm wondering if maybe we should form a subcommittee to work on this and see, number one, what our current payer obstacles are, what are their issues, what do the other states do to deal with those, and then maybe come up with a plan. And I don't know if time is a serious constraint for you to.
Well, it's a short session, and it is, and I've been reading the Hawaii bill, and I think they have some really good things in here. You know, I like that they address malpractice. You know, I thought that was critical because it says, you know, if it's going to be considered the same as face-to-face. So they actually addressed some of those things. They did originating site, and I thought their language was really good around originating site. But, you know, we're working on a bill. You know, I understand where the carriers are coming from because they have a profit that they have to make, but so do docs. And if we can't attract docs, we've got to find a balance. And so one of the things that came out of the meetings last year was they absolutely, I mean, they would listen if we took out facility payments. Well, a facility charge is a facility charge that mainly hospitals get to do, not the smaller providers. So, you know, Are you
talking about the facility fee that we typically talk about, like the $25?
No, we're talking,
the in-person facility fee.
In-person
sometimes
facility.
more than the actual pro fee.
Yeah, right.
Okay. And I know my institution.
Right. Yeah.
And they think we're charging for that in telemedicine?
They think that you want to be reimbursed for that.
And I would say no. Yeah. I mean,
so we were talking, and we were going to leave it initially up to individual contracts, but that doesn't take it out enough, and it doesn't give me the ability to say we've taken it out. We're not going to allow for, you know, that kind of payment.
Why wouldn't we just charge for pro fees?
For what?
Pro fees only. This is only.
Yeah.
What's a pro fee?
Professional fee.
Oh, okay. Okay.
Yeah.
Now, you're certainly the expert on this, but I'm just wondering if, I remember Teledoc's argument was that would take us out of the market for our e-consult $45 charge if you mandated the going rate. Is there a way to carve out telehealth somehow without going into each individual specialty and giving the carriers or giving the organizations the ability to negotiate, but not limiting it too much?
Don't you think the other states have already tried to tackle this, Official Penny?
They have.
Can't we learn from what they've tried, done?
That's what I'm hoping to explore more.
I mean, I would imagine that Hawaii would have data on like costs after, before and after. Perfect.
I think that's great to learn from other states. I guess I'll agree. A couple things. One, just representing Kaiser, so we're nonprofit, right? There's no motive to worry about costs. When I worry about costs, entirely because all costs are eventually a pass through, and they go back to our patients and our employers and back to all of us. presentation from Dr. LaRouche, telehealth, it's unknown if it's cost effective or not. We don't know. And so I worry about legislating or requiring parity payment for something that is not proven. That feels like we could be right, but we could also be wrong. And that could actually increase costs, which again is not anything anyone wants to do.
And I think that's what's caused me to rethink some of this and say, could we hone it down into maybe 4 areas?
That's why I wonder about the guardrail idea. And
yeah.
For me, the big problem areas of telehealth revolve around increased utilization. So patients will seek care that was really not necessary, or they'll be marketed care that wasn't necessary, think they needed. Or it's again like my example from rheumatologist, which we're both talking about, which is a presentation of 2 big hotspots. So for me, the guardrails around that are more, the tele-ICU, the telestroke, Project Echo, where it's specialty consultation. It's pretty hard to argue that these were done through marketing, that these were done, because patients felt like they just wanted to talk to you for some reason, or that these were not replacements for face-to-face care. I think they are. But I think in that more specialized area, the cost savings are probably greater, and I think the risk for abuse is lower, versus taking a specialty approach. Like VHS is a huge, huge pile of utilization, and I would worry about that specialty being the test case for parity, because VHS costs are already huge. What's VHS? Behavioral health services. Okay.
It's what?
Behavioral health services. And it's huge. And so that's not a small place to start. But if we start with a slice, like TeleICU, Project Echo, telestroke, those sorts of things, I feel those are less prone for those downsides of telehealth, if we could learn from that and start there.
So you don't see that cost savings component in there and access. I heard you say utilization would increase.
It does.
I'm just thinking more along the right care, right time, right place kind of thing.
You get both. So you will certainly get some appropriate increased utilization, which is what we all want, and you will get some inappropriate increased utilization, which just is cost and no benefit. And you'll get both. For the earlier presentation, we don't exactly know how much of each you get. That's why we don't really have a clear direction forward. A quick example, one way we try to solve that in Kaiser is we have online visits, which are directly marketed to our patients. They're very simple sorts of things, but they're handled by our nurses, and they take 4 minutes. And obviously nurses don't bill, so it's part of our prepaid cost. And if we get wrong on that, we eat it because it's our own cost. So that was a little example of things like that. I would be worried if I was paying a ER doctor, someone else to be handling, sore throats or UTIs in 4 minutes apiece for full value. That would be a pretty good business.
That's why I'm wondering if there's some way to carve those out.
Right.
And in that resolution rate, I know, like in Oregon, for example, it probably happens here as well, but Zoom Care, if you have a telehealth visit and they can't resolve it, you have to come in person, they don't charge you for that.
We do the same thing.
So,
But that's another good thing, right? They have a total cost of care approach and not a unit cost approach, where there's some skin in the game on both sides.
And I would ask you a question, and it keeps popping up in my mind, is if a teledoc visit is $25 to $45, because that's what we were hearing, $45 last year from one of the carriers, what are you reimbursed for that visit? You're not reimbursed anywhere near what they're paying to that contracted teledoc. That's not fair.
I don't know what the doc is. By you, do you mean the doc?
You're not getting reimbursed. You, as a physician, seeing a patient via telemedicine, are not getting $45 for a visit.
I wouldn't think so. I don't know.
So maybe one of our things is compare reimbursement rates and outcomes on teledocs versus everyday providers.
Oh, with teledoc, like what we pay for the platform. So we use Teledoc, but we use their providers right now, but we'll be using our own soon. And so when we use theirs, we make like $10. When we're going to use our own, we'll get about $40. So it'll be $9 a visit to the platform.
And are those physicians or mid-levels or what?
It'll be NPs.
Okay.
Yeah. And again, I'll bring up my German example. I know it's been proposed that if it's not a parity payment, people won't do the work. And in our case, that's not true. The dermatologist sees 60% more people per hour, and I don't pay them a dime more, and they like it. Because again, they get to come in at 9, or they get to leave at 3. They get to commute. They can work from home. Breaks up their day. I mean, you got to pay something, but I think I'm not sure it's a truism that parity is required for docs to find it useful to do. So can I just read something that Mark Lowe wrote to me? He said that I'm selling parity to providers as an incentive. I think I'm into it. So just like you guys, I mean, just like we're trying to sell to patients to make cheaper. I mean, so there is some disconnect here. And I just want to throw another idea from Jenny Cruz about what if we covered a certain number of telehealth visits for a time period, just like we do for like physical therapy or acupuncture, and then you can see what the utilization is. I mean, it still allows you to kind of put some constraints on it. So just reading some of the comments.
Yeah, but just, so in the Medicaid population is it's a different animal again, so we can act like a commercial unit in many ways because we can be flexible and we can do new things and that. But when it comes to reimbursement, I mean, we're under a cap. We have to manage care really tightly and closely. So when we offered all of our William Medicaid members 24/7 virtual care, so that's really the model. I would do anything to get those patients to see any provider. So we're incented to pay providers to please see our members, especially, to provide some access into these rural areas. So in that sense, parity is a good investment for us because we're just trying to get our members seen and prevent them from getting into here. Because they have absolutely, we have no way to disincent them. So because our members pay zero, for me, it's like, well, if I don't have a stick, I've got to have a big carrot. And the carrot for the Medicaid members is that this is convenient. This is, you don't have to bring 4 kids with you, drag you, take a bus, because you have no transportation to the emergency room for your care. You pick up the phone. How convenient is that? I know 60 to 80% of our Medicaid members have a telephone, whether it's a state phone. They run out of minutes and all that stuff, but at least they have access. And when we start looking at what works in terms of the marketing, it's huge in this population. It's all about social media. It's all about search optimization. And if we don't have that in place, the numbers are, engagement starts to tail off. And we're not finding a lot of, about 20% of patients who are using the service are repeat customers. So they're not abusing it. And this is a population that has huge abuse potential because they can do whatever they want. And they're not abusing it. In fact, we've identified those who are our highest using members, and we're trying to drive them to use it. If you use this every day, hallelujah, because otherwise you're using the ER 75, 80, 100 times a year. And I would much rather, that's not good effective management of stewardship dollars. We really need to be careful. So in the environment of the Medicaid environment, it's very different. Maybe it could be a separate use case, and maybe it could help to inform, others, but it's just different. It's different in the commercial market.
I'm sure we solved this, but at least we kind of aired things here. And looking at other states sounds like that's a good next step.
Well, there's some really interesting things in the Hawaii bill. I mean, I was, whoa, but we're going to write a bill. I mean, we're started, but we're in, and I'd like to get it out to you all in a draft form, and it won't be perfect, but no bill is ever perfect. But we need a starting place. And so no matter what, I'm going to try to get a bill dropped like ASAP, but I need your input, and then that'll help me to make amendments, et cetera. I know that Senator Cleveland is excited to see what we're bringing. So, Ian.
Well, I think I was just going to say that from listening, Brody and I have talked about this before, and it would seem to me that we're all siding to the other states that have, the 3 states that have gone down this road, and the Hawaii bill in particular. I think it would be just as important. Obviously, it'd be interesting. It's important for us to get feedback from the provider side, but I think it'd be great if our carrier representatives here reached out to their colleagues there about what the process was like, and whether they're finding it workable or whether it's a big problem.
I mean, let's expose the good, the bad, and the ugly of it, and see how people felt about how that process went. Because I think it'd be interesting to hear, and I get, because when the whole teledoc argument exploded in the last session, we were in the middle of session, and that's the worst time to try to figure out a complicated issue. Yeah, so I think it would be interesting to find out what everybody's perspective in these other 3 states has been on the process to get to where they got with the parity bill, but then what has the impact been so far? Because my guess is, as you said, Senator Becker, no bill is perfect, so my guess is there have been real downsides to it as well. I'll have to learn what they were.
We have a call Monday morning with ATA to talk about those, but she asked that we find out what were the major challenges we heard last time around. And then,
On the parity bill?
yes.
Number one, it's going to cost us more money. It's like, and he said it yesterday very clearly, and you were there, right?
Yeah.
Very clearly, it's going to cost us more money. It's another mandate, and what else did he say? I mean, he was ranting pretty good.
Yes, he was.
They're lobbyists.
Yeah, Premier contract lobbyist.
Oh,
Yeah, we
but
won't
I also talked with him out in the parking lot as we were leaving. I said, there has got to be a sweet spot here where there's a balance.
Well, but, and I get his point. I get his
I
point.
I get his
100%. In that he's like, look, we've been able to provide, and this is the point that Brody's made, that you've made to me, that we have been able to provide not only convenience to our insured individuals, but at a very discounted is the wrong word, but at a very affordable price. And if that goes away, how is it, from the carrier's perspective, how is it any different than an in-person visit? And I get that. So there must have been a process in these other states that they went through. And again, everyone may be happy about the result, but my guess is everybody probably gave a little bit too. So let's find out what that was.
I'm sorry. I was in on that meeting, and I heard his comments, and I also appreciate those comments, but maybe it's the nurse in me. Number one, we're talking a lot about reimbursement, but we're forgetting that we're taking care of humans. And you can't put a price on that. But the other thing is, so why are we arguing about the, lowballing a visit at a remote site when these people have a hardship, can't get access to care? It's a major barrier. We would reimburse the same amount if they could actually truck over a ferry, spend 4 hours in traffic, and spend $100 they don't have in ferry fees and gasoline in a car that makes it to Seattle. I don't understand what the argument is here, that it's okay to pay one rate if the person can show up in person at their own expense. And most of these people don't have a dime to their name, versus showing up when they're a covered client, a covered subscriber, and we want to lowball the reimbursement rate of the expert who's seeing them. I just don't understand it. And then meanwhile, we're arguing about money when we're taking care of humans. I'm sorry. I am happy to work on this bill, but I think we need to remember as we move forward here, I understand we're all trying to contain costs. I'm all about that. And managed care is a huge consideration here. But whatever language we can place in that document to drive these key arguments, I think is important. But we also need to keep our eye on the vision here, which is delivering care to people so that it's not a barrier and costing more downstream when they're not getting the care that they need.
Thanks, Joel. So I'll give like 5 more minutes, and I think that one of the action items would be if we could reach out to our counterparts in Hawaii, Delaware, and Minnesota to really understand. KPs in Hawaii, I have brethren there.
In Hawaii? Are you going to go visit them and find out?
The next slide is on Maui. In non-virtual. There is somewhat of a time issue with net neutrality. When does the comment period?
Not so much on the net neutrality, but on the rural healthcare program. So February 2nd, they would like comments back, and there's an extended comment on the comments period for a couple more weeks.
So it is in your packet of information. I would ask that you read the stuff that Denny forwarded. And I confess I am not up to speed on that at all, but Denny, I think basically your takeaway is that it's not such a good idea for telemedicine, this new ruling of net neutrality. Is that a fair statement?
Right, and for the last several years, the cap has been exceeded from 400 million to 560 to 70 million, and it keeps going up. And so right now, the FCC is looking for comment on whether or not they should expand it, or even thinking about disintegrating the whole thing. But they're also considering if they keep it in place, they might have to do a priority scheme and do a first come, first serve. So there's a lot of things they're thinking about. So they're really looking for some comments on specifically healthcare and how we can push healthcare entities. And the rural and the underserved are a big part of that for a lot of these organizations out there that have taken advantage of this forever and ever.
Denny, would you mind sharing your comments that you're going to submit?
Sure.
Yeah, and just so everyone can kind of see what your perspective is, well, we can obviously come to our own conclusions, but I'd like to just at least see what you're saying. Well, good. We're right at 5 o'clock, and I want to be respectful of people's time. Any last comments or questions?
Can I ask Senator Becker, would you mind forwarding the bill? But while I go, I'd like to actually read it.
Sure.
We're able to get that electronically. That'd be great.
I'll forward it to the whole.
Okay. Well, I apologize for not having a very extended public comment period here. If folks do want to add any comments, they can get on the record. Please email me. Michael, would you mind emailing me and I can put it in? I just want to be respectful for the folks who need to sign off. Okay, great. Thanks, everyone.